Hi, Jennifer.
Hi there.
Have you started? Sorry, I'm a couple minutes late.
Nope, we were waiting for you, I think.
Okay. And we've got a few of the residents on already?
Yeah.
Okay. Good afternoon, everybody. John Polovich here. Can't see people. Everyone has their cameras on. If possible, could you just pop them on just for a sec? And I will introduce myself, John Polovich here. I'm calling in today from my home in the Central Fraser Valley Traditional Territory of the Stolo Nation, and I help support the RTVS program through the Rural Coordination Center of BC. I'm a family doc, the medical director for Carrier County Family Services based out of Prince George. And some of you I may have met before, I'm not sure. But nice to see everybody. Glad you could attend this academic half-day session. Dr. Jennifer Kask is going to present on some prenatal care. So, so thanks for joining. And Jennifer, without further ado, I'll turn it over to you.
Sure, thanks. So I'm in Campbell River. I'm presenting from the traditional territory of the Lakota people, which is part of the Kwakwaka'wakw cultural family. And prenatal care is something that I like to do, and I do some of. And I have two co-conspirators here, Susie Shelswell, which you can probably see in the CRG LDU2 Zoom room. Susie Shelswell is our clinical coordinator on labor and delivery, and I actually met Shelley when I was a resident in Prince George, but she's a labor and delivery nurse now. So our objective today is to understand routine prenatal care and be able to offer prenatal screening with labs, ultrasound, genetic screening, to recognize special populations, and I have chosen in particular those at risk of preterm birth, and to know the indication for referral or shared care, and especially to be able to access this in rural and remote situations. So I took a look back to see what the 99 topics say about this topic, and they're pretty vague, as the 99 topics are, but hopefully we will hit some of those high points here. So this is a picture of what the residents looked like in 2001 to 2003. We were the people who were there. And in fact, if you were in Prince George, you might actually recognize Dr. Tammy Atia, who's listening to somebody's chest, and Dr. Catherine Texter, who is doing something to Galt Wilson's knee. And John, you might recognize Shannon Douglas up there, and Richard Beaver. And so that was a group of us who were Prince George residents. I guess we started almost 20 years ago. We're going to start off with a simulation, and we are, for these purposes, we're not in Campbell River for this, but we're in fact going to pretend that we're working in Alert Bay on Cormorant Island. And just yesterday I was actually in that part of the world, not in Alert Bay itself, but I was in Port Hardy and saw a patient from Alert Bay. In Alert Bay, there's a small emergency department. There's 2 beds. They don't anticipate providing like intrapartum care there. They don't plan to have births there. So I was asking my patient yesterday what they have, just can you remind me what you have at the Alert Bay Hospital? And she said, oh yeah, we had a birth a couple of weeks ago. So I thought, oh well, then this is a genuine simulation then. So we're going to pretend that Lexi is a 26-year-old gravid 2 preterm 1 L1 who presented to our situation here at 33 plus 1 weeks gestational age. So I'm just going to clear my throat. So her estimated date of confinement is July 15th based on an ultrasound done at 10 weeks and 2 days. She came in early this morning. She described waking up with some cramping in her lower abdomen, which started at about 1 a.m. She's otherwise been well and she can feel the baby moving. She's had some mucousy vaginal discharge, but no fluid loss or bleeding. Her past obstetrical history is about 2.5 years ago. She had a baby girl who was born at 36 weeks, 5 days. Here up in Campbell River. I'm not in Campbell River, I'm in Alert Bay, I have to remind myself, but born in Campbell River. The weight was 2,540 grams. There were no complications in birth. She has no allergies. She's on no regular medicines. So for initial assessment, she comes in and we take her temperature and her blood pressure is a bit high. She's quite nervous. She's got a heart rate of 96. The fetal heart rate's 140. And the abdomen is soft, it's not tender, but she is cramping every 2 to 3 contractions in 10 minutes, and they're lasting 45 seconds or so. We did a symphysis fundus height and undertook a point of care ultrasound. And when we did the point of care ultrasound, this was putting the ultrasound probe right on down just above the symphysis. And you can see that in fact there's a nice cephalic head. And we just looked up the edge and we could see the spine and see a nice fetal heart there. So I don't know, like I haven't worked in Northern Health for, well, since 2005 when I finished a couple of years of practice and moved to Campbell River. But in Island Health, small communities like Port Hardy and Alert Bay and Port McNeill have something called the, well, we call it pig fib because it's got a really long name. And this is actually a point of care test that is done. And maybe you guys can speak, well, John, do you know if you have that in Northern Health? That's something that you use for preterm birth?
We don't have it in the remote Indigenous communities.
Okay.
But
anyways, we have it in our small communities, and it's very similar when it comes to ruling out preterm birth, as like its negative predictive value is very similar to fetal fibronectin, but it has the advantage of being a point of care test. So this is in our emergency department. We think, oh, well, let's do a sterile speculum exam. Let's collect the pig fib. And this is just the instructions for how to do it, but I won't persist in that if it's not in your part of the world. But basically, if anybody's ever done a point of care throat swab, where you swab something, you swab it for 10 seconds or whatever, then you put it in the buffer up and down for 10 to 15 seconds, you discard the swab and you're left with a buffer, which is, you know, the stuff from the back of somebody's throat, or in this case, the bottom of somebody's cervix. Then you use what looks like a little pregnancy test. You sit it in there for 10 to 15 seconds. 1 line means negative, 2 lines means positive. And in this situation where somebody's come in with cramping and maybe we can't tell if they're in, you know, preterm labor or not, a negative test would be helpful because it does have a very high, you know, negative predictive value would be she'd be very unlikely to be going into labor in the next 2 weeks. But a positive test doesn't help us any more than clinically what we have in front of us already. So we undertake the speculum examination, and when we examine her with a sterile speculum, in fact, we can see that her vagina is mostly filled with the bulging sac of membranes. And in fact, we can see the hair floating in the fluid, and it looks like she, you know, we take this back out carefully and examine her, and she's the cervix is actually quite thin. She's 6 centimeters dilated, and station is at spines, but her membranes are intact. If anybody wants to chime in at this point and ask any questions, please go ahead. Anything that...
Don't feel shy, everybody. Anybody have any comments about the pig fib point of care test?
We can always come back to it too, but it's in fact I did one yesterday in Port Hardy.
I've seen it used before. In Surrey they're using it, so it's not just in small communities.
Oh, good. Yeah, good. Well, it does have it's way cheaper than a fetal fibronectin, and its negative predictive value is the same essentially. So it's very useful for ruling out.
Is it in Prince George? Sorry.
I haven't seen it in Prince George.
Okay.
And the other advantage is, of course, that it is basically we can get a result, you know, within, I think the instructions are to leave it for 5 minutes or something, but much faster than, oh, I'm going backwards here, much faster than waiting for the fetal fibronectin. Okay, so anyways, now we are at an inappropriate site for birth. We are in Alert Bay, which is a ferry ride away from Port McNeill, which is about 2 hours by road ambulance to Campbell River, which is a rural hospital itself, which we don't have a nursery. So So the closest nursery for somebody who's 33 weeks is actually Nanaimo, which would be another hour and a half from Campbell River. So we are 1 ferry ride and 3.5 to 4 hours, depending on traffic and weather, away from a nursery. So, but we call the patient transfer network. So we get them on the phone and we connect with the perinatologist who gives us some advice regarding corticosteroid use, tocolytics, antibiotics, magnesium sulfate, which we didn't start in this case, but the perinatologist as well. BC Ambulance Service isn't going to be able to transfer this multiparous lady with a cervix, who seems to be in active labor with a cervix that's already 6 centimeters dilated. And so let's give her a dose of the betamethasone. Let's start her on penicillin. We'll give her 5 million units IV now for group B strep prophylaxis. We'll give her a dose of nifedipine, although it does look like if her blood pressure will support it, but it really looks like she's likely going to deliver. And it's going to be a bit of, you're going to be probably delivering this baby. So what can we get ready? Now, I might not be a provider who's comfortable at all with doing this. So this is where we might want to call a friend. Any suggestions? I think I can invite somebody in here.
Come on, team. Any suggestions from the group?
I'll give you a clue. It's the RTVS rounds that we're doing today.
Jennifer, don't give it away.
Oh, okay.
Mabel.
I'm going to call Mabel. Yeah.
That's
so
excellent.
Mabel is the mothers and babies advice line. And so if I ring up Mabel, I'm going to see if I can add Mabel to my Zoom call here now. So I'm going to invite Mabel in to our Zoom and we'll see if we can't get Mabel on the line. Because we're kind of freaking out because we haven't delivered a baby in a while. Although we had a very good residency program in Prince George. So we are we've been well trained to deliver babies and to do neonatal resuscitation. But this is something that we haven't done anytime recently. Now, I should be able to bring Mabel in. Oh, here's Mabel.
Hi, it's Ashna Naji for Mabel. Jennifer, I'm just on another call. Do you think we could connect in maybe 5 minutes?
Yeah, absolutely.
Sorry about that.
I know what advice you're going to give me, so this is one of the risks we run. So that's no problem. Hang up on me and I'll carry on.
Yes. So do you want to call me back in 5?
Yeah, sure. If you think 5 is enough. Okay.
I hope
Thanks
so. Yeah.
so much.
Okay. Perfect.
Yeah.
Thanks. Okay.
Okay. Thanks.
Bye.
Bye. All right. Well, sometimes Mabel will be busy, but fortunately, we can call another friend. Somebody else might have some expertise here. So what are the things that Mabel might tell us to do? Now, you guys, we're going to have some audience participation here. What kind of things are we thinking of if we're going to deliver, if we have sort of an imminent birth? What kind of things do we want to get ready for somebody? Anyone?
Don't be shy, people.
Oh yeah, so prepare NRP equipment. Okay, so I'm actually gonna see if I can't get this screen to share over here. And I'm gonna go on mute so that you can hear me through the other screen here, because I'll just do it through that part for now. We were having a lot of feedback using 2 different screens in the same thing, but I'm just gonna take us over to the labor and delivery screen. And more, share content, screen. Okay, you guys see that now? Oh, screen bug. It's thinking. Well, if this doesn't work, that's going to be irritating. You are sharing screen. I'm sharing. Okay, I don't know how well you guys can hear us now. And feel free to, like, it's going to be hard for me to see the chat at the same time. So feel free to just call things out. I hope there's not too much noise here. Is this actually sharing the screen? Is this, oh, it says I'm sharing screen, but then it has just a screen share thing. When in fact, we want to share the video. Well, this might not be working very well. Gosh, sorry guys. I will stop showing that. I'm gonna go back to this screen here.
There's some comments in the chat.
Oh, he's come back up to our Zoom screen.
You're on the Zoom screen. Oh, okay. I just can't make that one the biggest one. Okay, so maybe what I'll do is I will bring this one over.
Jennifer, can't hear you. I don't know if that's.
Yeah, let's try that. Yeah, no, I probably just muted it accidentally. Okay, so we've got our intubation equipment, we've got our LMA, so we're ready there. We have the warmer on. We'll also turn up the heat in the room so that it's nice and warm because we are expecting a preterm infant. We've got a hat. We've got some warm, dry linens. I think we're ready there. Okay, let me see what else is in the chat. Make sure where the radiant warmer is working. Yeah. Okay, suction. Anything else that we need? We're feeling pretty good about this. We got our SATS probe. Okay, perfect. Okay, so we're just gonna hopefully we'll get some more help. Anything else that people are kind of thinking of in terms of I guess management before a baby arrives? Anything else that
we need to make sure what are the risk factors, how premature is the baby. I'm sorry, I just I joined a little late, but I just need to know what were the circumstances. Was the mother in a car accident? Was there was there any blood loss? Are we expecting the baby to have, decreased blood volume? And in that case, we would be requiring to, we would be making sure we have epinephrine, we have fluids, and all that stuff.
Yeah, absolutely. So in this case, what we'll also get ready is we will get things ready for medications in case we have a prolonged resuscitation. So we might have the only medications that we use during NRP are epinephrine. And so we can make sure that we have that available. We'll make sure that we have something available so that we can do so that we can gain venous access if we need to. Yeah, there wasn't anything. This was a 33 plus 1, and she has just seemingly gone into spontaneous preterm labor, having had a previous preterm birth in the past. So, okay. But we'll have those things prepared as well, just on the tray behind us here. And that's probably the biggest thing, is that it's really anxiety provoking when you're waiting for a baby that's being born and you know that you're a long ways from somewhere. Warmth, you need to provide warmth to the baby. Okay, so, and we're also rechecking the mom. She seems to be tolerating this well. She's requesting some Entonox, so she's using some of that for contractions and breathing through her contractions. And she's got a partner with her who's supporting her. Yeah. And I didn't pay attention to how long it's been before I can call Mabel. Did anybody think it's 5 minutes yet, or should I? It's been 5 minutes. I'll try her one more time. And if she's not available, we're going to keep moving on.
Any other questions from the group here? Brody, I see you came off of mute. Do you have a question?
So if I just drive the labor and delivery one around, does that work okay? Can you guys see? I don't know how to make that be the biggest screen for you guys. Do you know how to do that?
So if people go on speaker view on their Zoom, that should make it.
Hello?
Oh, hi. Is it okay time? It's Jennifer.
Perfect. It's perfect. Sorry,
it
so
perfect?
sorry about that.
Oh,
Yes.
yeah,
Okay,
no,
let's
no
start out.
worries.
Let's start
Okay,
again.
so
Hi, it's Asner Naji, family doctor from Mabel.
Thank you so much for taking my call. So we are all ready here. We have a lady, Lexi, who has come in. I can give you her PHN, which is 9080123457. And she has come in at 31 weeks gestational age in spontaneous preterm labor. She's had one uncomplicated preterm birth in the past, about 2.5 years ago. We examined, she's had no complications in this pregnancy, and we are sure of her dates because she's had a normal ultrasound. She had an ultrasound at 10 weeks. When she came in, she was having some cramping, and when we examined her, this was about 30 to 45 minutes ago now, her cervix was 6 centimeters dilated and bulging membranes. I have spoken to perinatal services, to the patient transfer network. Patient transfer network. And they have said ambulance won't take us because she's too far
imminent.
along. And in fact, just since we were calling you, she's gotten a lot more active. She's really feeling more pressure and things too. I'm actually going to mute here and move over to a different screen, I think, so that we can see better, but we're going to try again and see.
Okay. And I'm assuming that in Alert Bay you have a birth kit and a warmer and all of that handy?
So we actually managed to get everything ready already. Awesome. Can you guys hear me here? Yeah. So we just checked the warmer and everything's ready. And you can see that I've got 2 nurses here.
Yes.
And we have heated up the room. And this is
wonderful.
Lexi over here on the bed. This is Lexi.
Hi,
Lexi. Yeah, she's working really hard. She's doing
nice
so
to meet
good.
you like this.
Yeah.
Well, Dr. Kask, looks like you have everything under control so far with the warmer and the rooms and the nurses and everything. So, that's wonderful. What else have you got going?
So we do have an IV that's going with some penicillin. Is that right, Shelley?
Yeah, she's had it. One dose of 5 million units.
1 dose there. And we also have given her some betamethasone.
Wonderful. Great work.
Oh, what's this? I think her water broke.
Uh-oh, her water has just broken, Dr. Neck.
Okay, and you've got everything that you need, Dr. Cass. So I'm here if you need me, or if you need me to walk through things, if you want to walk through things.
Fetal heart rate. Yeah, we're just going to
Okay.
listen to the fetal heart again. How's it sounding, Shelley?
140.
140. Okay, good.
Wonderful. Okay, so you're preparing for delivery.
She's like pushing. Hang on. She's pushing.
Okay, that's okay.
Yeah.
You've got this.
Okay, yeah. I really just remember that Dr. Texter told me to slow it down.
So as you're doing this, Dr. Kasky, we'll hope for delayed cord clamping and then hopefully skin to skin if all else goes well, right? If color, tone, baby's crying, you've got some towels ready, I'm assuming.
Yeah, we've got nice warm towels and everything's ready. Oh wow, she really is pushing it. Okay, the head is warm. Okay. Cool. Okay. I think that's. Let's see if the rest of the baby will come.
Do we have a dystocia?
I don't know if we have a true dystocia or a dull dystocia. Oh, there we go. Shoulders are coming nice and easy.
Wonderful.
Here, Lexi, your baby. Here comes your baby. Oh, can we put it right onto her skin here?
Wonderful.
Okay.
How long is the cord here?
It looks
So
like
it's 1:29, so you have at least 30 seconds or up to 2 minutes.
Yeah, we're
so
right
it's
on baby's mummy's chest.
Oh,
Lovely.
The baby looks like it is early, but it's crying and breathing, and the tone is good.
Great. Wonderful. Congratulations, Lexi, Dr. Kask, and the team. That's awesome. Welcome to our
Get
planet.
some dry linens here.
Okay,
Oh, sorry.
great. And we can change those up.
Okay, good. Good, yeah. So the baby does look, it's crying and crying. I don't know if you can hear it on your end. But this
No, I
sounds
can't,
good.
but
Yeah, she's got,
wonderful.
it's a beautiful baby and
Okay.
lots of wiggling.
Great.
Good
And the
tone.
heart. Okay, great.
The heart rate? Do you,
I'm
can
at
you grab
50.
the, you grab the stethoscope?
Wonderful. Wonderful.
So should we just, how long has it been now?
A minute.
Has it been a minute?
Probably just tell us 55.
So maybe just grab my equipment so that I can clamp the cord over.
Perfect. And I don't know if a partner is there and wants to help with the cord clamping, cutting.
Here, ready? We'll get Sheldon to help cut the cord here.
Okay.
Here's my clamps.
Wonderful. That's the fun part.
There we go. Maybe we can move the baby up on Lexi again. Get another warm blanket there. Okay, so Shelley, are you comfortable with the baby here?
Yes, I'm good
And
with
we'll
the
just, is that okay to keep the baby just with Lexi for now?
Absolutely. And what I'm wondering, Dr. Kask, is if you want to patch in Charlie with just making sure baby's okay, I'm happy. I know that you've given me the PCHN and baby's registered, so I'm happy to touch base with Patient Transfer Network if that's helpful for you to just kind of help coordinate things in the back end while you kind of focus on mom and baby. It sounds like you've done a beautiful delivery.
Yeah, that would be great. I think I just need, we're supposed to give oxytocin or something, I think.
Yeah,
And I think we just
yeah.
forgot that because
I was
we
just
are
gonna,
so-
yeah.
We're so out of practice here.
No, but you've done
Yeah.
wonderful. And
So
so
we've
it's
got some,
active
and
management
then I'll
of the
just-
third stage.
Yeah, I'll
Yep,
just make
you
sure
go.
the placenta comes okay.
Perfect. Yes. And if you need with a retained placenta, then, you're more than welcome to give me a call back. But I think with the oxytocin and the active management, so, all the things, the cord traction, et cetera, I'm assuming the placenta will come quite quickly and easily for you.
Yeah, it looks like it's out now. We're just
Lovely.
massaging down and everything looks good. Yeah, if you don't mind calling Patient Transfer Network, that would be
Yeah, absolutely.
amazing.
Yeah,
We'll-
absolutely.
Yeah, we'll make sure that we get,
me now.
and we'll just keep watching the baby here like this. And then
Perfect.
I don't mind calling Charlie. Are you gonna sign off or do you want to?
Yeah, if that's okay, I can
Yeah.
go ahead with the Patient Transfer Network piece,
Okay.
and then you can connect with Charlie. And if you need anything, then feel free. I'm happy to be here as another sounding board for you.
Okay, thank you so much. I'll maybe
you're
call Charlie in here.
Okay,
Thank you
you're
so much.
You're welcome. Congratulations to you and Lexi and the team there. Okay, take good care.
Thanks.
Bye. You're welcome. Bye.
Okay, I'm just gonna see if I can't bring Charlie in.
Oh, she's so good. Look at Lexi, you did so great. Where did Sheldon go?
You guys see okay? Where's little baby here?
The baby looks all
Can you see the
healthy
baby
and
okay?
happy.
Let's see.
I think it's rooting.
The baby's rooting.
Senior nutrition here.
Oh, good. Hi there. I'm Dr. Cass, and I'm from Alert Bay, and we've just had this baby.
It's now
Yeah.
4 minutes ago.
Yeah. So I don't know if
Perfect.
you can hear me very well. This is
Yeah, I can hear you
this
great.
is
I've got a
baby.
Yeah,
She's
go ahead.
33 weeks 1 day. Was born rather precipitously after in Alert Bay. Came out crying and with good tone and good color. We've just kept this baby on its mom's tummy for now because she keeps crying and crying. And we did delayed cord clamping. And Dr. Nagy from the Mabel has called Patient Transfer Network because of course we don't have any way to care for a 33-weeker here. And so we're just looking for some help, like how can we sort of continue to assist this baby in the next little bit while we're waiting for transfer.
Yeah, for sure. Thanks. That's a great summary. And the baby, how's their tone right now?
Can you see the baby? The baby's got excellent tone.
Wonderful.
And the baby's crying.
Perfect.
Yeah,
I can see the color a little bit. How would you describe the color of the baby?
Pink.
Yeah.
And she's got a little bit of acrocyanosis, but other than that, she's looking really good.
Perfect. Any vital signs yet? Any heart rate, rest
Yeah.
rate?
The nurse, I think, here can tell you what the
Heart rate is 150, rest rate 55, and the temps 36.8.
Perfect. And sorry, heart rate?
Heart rate was 150.
Perfect. And we're just drying and stimulating right now?
Yeah, we're just, these are nice dry linens. She's just on her
Brilliant.
mom to stay warm. So
It's great. Sounds like you guys are doing everything right so far. Do we have an O2 sat yet?
Yep, it's 92 at 10 minutes.
Awesome. Perfect. And so I just make sure that we keep the baby on mom's chest. I think that's great for now. I'd keep this O2 sat probe on just to make sure we continue having great sats and a good heart rate. And then I think we should probably transfer baby out. It sounds like you guys need a few more resources.
yeah, and I think we're getting Patient Transfer Network into the queue also. I think I might just be getting a message here from Dr. Nagy that in fact they are going to be coming right away. So we're quite a ways, but it'll probably be here in the next hour or so.
Fantastic. So right now I just leave that O2 sat probe on, just do vitals at least for right now, Q 15 minutes, and maybe go to Q hour after that if they're all stable.
Okay.
It doesn't look like we need any kind of positive pressure support.
No, she's really crying a lot.
Yeah, awesome.
Yeah.
That's great. And
Can we just call you back if we have any problems before the infant transport team arrives?
of course, for sure. Do we have any baby name yet?
Sheldon.
Lexi? Oh yeah, it's named Sheldon after the baby's dad and after the
Perfect.
nurse.
Wonderful. Okay. And probably no PHN yet.
I think that we did get the baby registered,
did.
so I think
Okay.
the baby's PHN was 90801234567.
Brilliant. That sounds great, guys. Okay, well, great to
Orange
chat with you guys. Please call back anytime. I'm around all day.
Okay, thank you so much.
All right.
Close
Take care. Bye. Bye.
Thank you. Okay. Okay, well, now I'm going to take my mask back off. Okay, any comments? Anything that you'd like to debrief as part of this?
Jennifer, that was a great job. And that's a tough place to be in a small community like Alert with a patient such as you had. So it really underscores the importance of the teamwork and most importantly, the people on the ground, but also what's available virtually now to support people. So, so I've sent out in the chat for everyone just the last version of our RTVS toolkit, which has all the RTVS pathways, as well as a kind of infographic for people to look at. And so I guess on the call, does everybody have a Zoom account? People could.
Yes.
Good. And do you have, who on the call actually has a Zoom account from the RCCBC, the Rural Coordination Center of BC? If that even rings any bells.
Believe that I do, from a prior information, prior session that we had on this topic.
Good. Is this Paul talking?
Yes, it is. Yeah.
Okay. Paul, do you want to, can you, oh, there you are. Nice seeing you. So and looks like some other, Georgie, do you have it too? So the advantage to having the RCCBC Zoom account is that under contacts, all the RTVS kind of contacts are pre-populated on the version. If you have a Zoom account from a different provider, obviously these things are, the RTVS pathways are still available. It's just that in order to import the contacts into your existing Zoom contact list, it just requires a little bit of a few extra steps, which we can help you with that if need be. So I strongly encourage you, if possible, to get an RCCBC Zoom account that comes preloaded with all these things. So any questions for Dr. Jennifer around this good case? And has anybody been involved with a preterm patient? Preterm delivery there in Prince George? Or is everybody on the call today from, where is everybody calling in from, by the way? Prince George, where else? Paul, you got to help me.
Yeah, I think everyone here, this is all Prince George and or Northern Rural.
Nice.
Yeah.
So who's had experience with a preterm delivery?
Yeah, I mean, I definitely have in Prince George. Yeah, vaginal, maybe, like 35, 36 weeks. And then, even a little bit younger via C-section, I think once or twice during my obs rotation. Yeah.
Okay.
So I mean, we still have some time left, and really, like, babies that are born preterm can be very, very stable. This, I think, was fairly, well, not atypical, depending on why a baby's born preterm. If they are just born preterm because their mom has gone into labor, often they are fairly stable, but they will tire quickly. And clearly we can't care for a baby who's 33 weeks in alert bay. So they need to be in a place where there's a nursery and some expertise around that. But, keeping things calm and not panicking and doing the delayed cord clamping. If we do delayed cord clamping, we give that baby, especially if there's no rush to clamp the cord, because they don't need any resuscitation. This baby came out pink and crying and with good tone, then we can delay cord clamping, which reduces their risks of intraventricular hemorrhage and anemia and other things. So, and then we, when maybe, like you could see, we talked to a pediatrician. It was kind of like, hey, this looks good. I'm here if you need me, and keep the baby on its mum so that it's, got good temperature management, and we can monitor until we have somebody, the infant transport team, arrived. I actually am not a pediatrician. So what gestation do we administer surfactant? I would defer to my pediatric colleagues. You do need to intubate the baby to administer surfactant. So in a baby who is well like this, who's breathing and crying well, I have no inclination to then intubate the baby to administer surfactant unless I thought that was needed. I feel like I might make the situation worse rather than better. In a baby who's otherwise well and not grunting and things. And you're right, I don't know that we would have surfactant in Prince George. We do have it in Campbell River. So I kind of wanted to take the temperature in terms of, would you guys like to talk a bit more about regular antenatal care, or I do have a particular interest in preventing these kinds of things from happening with some prevention of preterm birth information. And I'd love to share that if you guys wanted that information. But I need like a show of hands or something like that. Who wants to just talk about antenatal care? Show of hands. You guys have a little hand reaction thing, don't you, that you can put up your hand in the reaction thing?
Was that antenatal as opposed
Just like
to
regular sort of antenatal care versus preterm birth resources, prevention of preterm birth resources. So, but we have to do it one at a time because we're not getting a lot of feedback here. So who's in for antenatal care? Show of
Paul, you gotta
hands.
speak for the group.
Paul says yes, but who wants to talk about, oh yeah, Aram says yes. I might be saying that wrong. And then we do have prevention of preterm birth also. Oh, Cassie put up prevention of preterm birth. Marie, oh, we need a few more.
Cassie has a hand up. Cassie, do you have a question, or is that meant to
I
be
think
a thumb?
that's the,
That was a vote for preterm birth resources.
Nice. Okay. good
okay,
work.
well, maybe we can hit a little bit of each. I just don't want to be giving you a talk that you've already had, you know, about regular routine antenatal care.
And just to jump in, Jennifer, it is, if people can flip their cameras on, Paul was kind enough to do so. It makes the interaction a bit richer if that works out for people. So
I also recognize that, you know, it's Friday and there's probably other things going on. I did put a folder, like a link to a folder in the chat, and that should take you to a Google Drive that does have some preterm birth resources. I'll just go back to my PowerPoint here. And so, because I mostly wanted to do a simulation to see if our new Zoom on a stick would work. So you guys can give some feedback if you want to tell us whether it worked or not, but not perfect. Okay, so I think we had equal routine prenatal care or prevention of preterm birth. Maybe what I'll do is I will very quickly just go through some of the routine care, and so that we can get to the other stuff. So basically, I don't know how you guys have been taught to do it. We typically establish care, do a first visit, and then because there's so much to talk about at the first visit, we'll often do a follow-up visit where we do the physical. Every 4 weeks, you see somebody until they're 28 weeks. You see them every 2 weeks, 28 to 36 weeks, and you see them weekly after that. In total, I was trying to summarize it into basically you're going to do 12 to 14 lab tests and 2 ultrasounds over the course of somebody's prenatal care. And then we have postpartum and delivery care. I had another case, but I'm going to skip through it for time because we only have about 15 minutes. So if we do a first visit, has anybody seen, this one's one from BC Women's Hospital that actually has, like, you can spin the wheel, put it on their gestational age, and then it will tell you what to do when, which is kind of a nice thing. I'm sure that there is an app for that, but I don't know of a BC specific app for that. So what some clinics will do is they'll actually spin the wheel once we know when their dates are per ultrasound, spin the wheel, take a photocopy of it, and then pass it to the patients or scan it into the chart. And it just shows us where the tests are. There is a neat resource that came out of the Division of Family Practice in Vancouver, expecting little boys and girls. So the E stands for estimate and confirm their due date. L stands for lifestyle counseling and supplements. B stands for blood and urine testing, and G stands for genetic testing. And those would be things that you would do at a first antenatal visit. So a first prenatal, everybody's probably seen the antenatal record. This one's actually the old version and not the 2020 version because I don't have that in my EMR yet. Oh, the biggest thing I actually wanted to say here was when somebody tells you they've had a baby before, ask for the circumstances around that baby because, for example, our lady Lexi had a previous preterm birth, which puts her at risk of having subsequent preterm birth. And so if you take somebody's history and they had a preterm, say that Lexi comes in 2 years and she says, oh, my first baby was born at 35 or 36 and 5 in Campbell River, and my second baby was born at 33 and 1 in Alert Bay, and she's pregnant again, you might have some suspicion that there would be something you would want to do for Lexi moving forward. Hypertension, also a risk. If she had hypertension or preeclampsia in her previous pregnancy, you might want to intervene by offering her aspirin for prevention of preeclampsia. Dating ultrasounds. Now, if you're all in Prince George, you have access to ultrasounds. There are some small sites, or sometimes you'll just meet somebody early on in pregnancy and you know that it's going to be hard to get them in. And this is just a resource for how to do a dating ultrasound. And I think some of you will likely be much better at that than I am, because you're growing up doing your training in the era of access to point of care ultrasound, whether that's in the emergency department or sometimes in your clinics themselves. So basically, you just want to make sure that you put the probe in the transverse, you put it at the superior to the symphysis fundus, and you have the marker pointed to the patient's right. And then you're going to landmark, and you're just going to sweep it up toward the patient's head and sweep it back down. You're going to turn it so that you're then longitudinal and sweep back and forth. And you should be able to see that there's, you'll see the bladder, which kind of looks like a rectangle at the top. Then you'll see the uterus. You should see a black circle in the yolk sac. So you'll sort of see the double bubble, which will confirm that you have an intrauterine pregnancy. And if you have little calipers, you can measure crown rump length, and most of the ultrasounds will figure things out for you on after that. This is just an example. Actually, I think this is one that I did. Sweeping through, you can see a little, and so that confirms an intrauterine pregnancy. That was in the transverse, and then this is just, I couldn't figure out how to make it do it, but you can see a little fetal heart there on this view. Pre-pregnancy BMI, so you'll want to take a height and weight at your first visit also. Discuss pre-existing diabetes, aspirin. Prenatal genetic screening. It could be a talk on its own. So rather than having a talk on its own, I will say that the best place to go for information is to the Perinatal Services website. In BC, funded is IPS and SIPS. So IPS, if you are over the age of 35 at the time of delivery, you have your 2-part blood test, which is SIPS, and a nuchal translucency ultrasound. And there is nuchal translucency ultrasounds are not offered everywhere in the province, but there is a list on the Perinatal Services website of which communities have access to nuchal translucency ultrasound. If somebody you meet them for the first time and they are already past the dates where you can do your first part for SIPS, then you can also offer a quad screen from which is just the one-time blood test. There's some great resources there around decision making for patients and timing for tests. This is sort of their algorithm that describes how to determine who to do what for. There's also in BC available the non-invasive prenatal screening, which is the NIPT test. This speaks to what we have available in Campbell River and in our part of the world anyways. But again, if you go to the Perinatal Services website, it will talk about which labs have what available. The Life Labs is the Panorama, or BC Biomedical Labs Panorama, and in our part of the, like in Island Health, the Island Health tests have Harmony. So it's all, again, it's all on there on the Perinatal Services website, including where you can get it. As the pregnancy progresses, we just want to make sure that we've got healthy weight gain. You can talk about ultrasounds get done. So dating ultrasound between 7 and 14 weeks, anatomical ultrasound 18 to 21 weeks. This particular case, she had an elevated BMI and she had a marginal cord insertion. So she had an ultrasound at 32 weeks for growth, and she was really tired of being pregnant, but then she went on to have a baby and she had non-complicated delivery. I will just skip through this. This actually speaks to adolescent pregnancies. There is an SOGC guideline around adolescent pregnancies, and the important thing to recognize is that adolescents are a particular risk of preterm birth, and they are also at risk of having sexually transmitted infections. So we screen everybody for sexually transmitted infections, vaginal infections, chlamydia and gonorrhea and trichomonas at their first visit, but adolescents should also be screened in the 3rd trimester. So that's actually our MOA with one of my colleagues' babies, I think. So vulnerable populations, I see quite a number of adolescent pregnancies, people who live remotely and rurally. I think really sort of saying what works best for you, how can we make these visits work for you, how can we make care accessible. I really want to play to their strengths. We have women who live in very hard situations, but who have excellent families and wonderful senses of humor, and they're incredibly resilient and resourceful in the face of some situations. Okay, so preterm birth, this is what I also wanted to talk about because I do have a special interest in this. Where I live, we, like BC, or VHA has a Island Health, I should call it, Vancouver Island Health Authority or Island Health. Our rate of preterm birth is 8.6%, but to the north of me, when I drove out of town yesterday morning to work in Port Hardy, I went into the health area 85, which had a rate in 2016-2017 of 24.7% of their births were preterm. And if I drive to the west of me, very similar on the West Island, and because our hospital is the referral hospital for both of those health areas, we do see a lot of preterm birth or women who have a previous history of preterm birth, and it is the biggest cause of neonatal death and of course of disability as well, including cerebral palsy, chronic lung disease, hearing loss, blindness. It's really stressful for families. You can imagine if you have to travel a ferry in 3.5 hours to get to your closest nursery, and you have a 2.5-year-old, and you have, a partner and other aunties and uncles and all those things. It's very stressful to be in a nursery, and it's also extremely expensive for the health system. So anything we can do to prevent it is helpful. There are a number of things which have been tried and are not effective, including hospitalizing them for long periods of time, bed rest, apparently support during pregnancy, but that doesn't mean you should stop supporting people during pregnancy. Home uterine monitoring, psychosocial interventions, progesterone for multiple pregnancies or progesterone when somebody has a threatened preterm birth, antibiotics, oral tocolytics, cervical cerclage in multiple pregnancies or cervical pessaries. But there are effective interventions such as nutrition education and diet and exercise, fatty acids, omega-3 and marine-3 fatty acids, zinc, calcium, screening and treating genital infections. So that includes chlamydia and gonorrhea and trichomonas, but it also includes treating bacterial vaginosis and treating yeast because it does set up some inflammation, which might be implicated in the cervix shortening and opening or in pre-labor ruptured membranes. Secondary prevention when somebody's had a history of preterm birth, diet and lifestyle, weight management, smoking cessation, and progesterone for prior preterm birth, progesterone if there's a short cervix, cerclage for singletons if it's indicated, and antibiotic prophylaxis for PPROM, and aspirin and calcium for prevention of preeclampsia. So those preventions of people who have perhaps a iatrogenic preterm birth related to the preeclampsia that they had, where we delivered somebody early because they had elevated blood pressure or preeclampsia. If you have a previous history of preterm birth, we have done a quality improvement project on a preterm birth pathway in our part of the world, where we say if you have a history of preterm birth, even one preterm birth, even late preterm like Lexi did, we would screen you for infections at booking and monthly. So we treat any positive results, whether that's bacteriuria, bacterial vaginosis, yeast, chlamydia, gonorrhea. I should put gonorrhea there, but I just hardly ever see gonorrhea. I see chlamydia and bacterial vaginosis and yeast. Cervical length, we would do an ultrasound, a specific ultrasound for cervical length at 16 weeks. It will be commented on at the 18 to 21 week anatomical ultrasound, and then recognizing if somebody has a short cervix commented on by the radiologist at that ultrasound, that's of significance, and between 22 and 24 again. And then progesterone therapy, initiating that. There is an SOGC guideline, which was updated in June of 2020, which gives a moderate to strong recommendation for progesterone therapy in anybody with a previous preterm birth. The link that I put in the chat does have that SOGC guideline in it, and it has a few other resources, including this. This is my pride and joy right here. You will all recognize this as a special authority form. But this special authority form gets you micronized progesterone for free for women who qualify. And this blood, sweat, and tears obviously went into this, because anytime you have to talk to pharmacare that many times, you lose a part of your soul. But it all came out into this special authority, which I have not yet had rejected, and I think we've been using it for 4 years now. So if you want to use this, print it out, put the patient's name in and things, and then circle whether you need 200 milligrams a day vaginally or 400 milligrams a day vaginally. It's vaginal micronized progesterone. And the pharmacy or the pharmacare does want the dates of use. So if you're starting it at 16 weeks or up to 24 weeks, depending on when you recognize she has risk factors, then you put in like now through. Now in Campbell River, we have been using 37 weeks because that is term, and we are a hospital that does not have a nursery, but the guideline actually says 36 weeks. I cannot tell you how many times I've told somebody to take it to 36 weeks and then they've delivered at 36 and 4. And I thought maybe if I told them to take it to 37 weeks, it would have been 37 and 4. So because we're family physicians, we can prescribe that progesterone. Midwives cannot prescribe the progesterone. It falls outside of their scope, and they might refer to an obstetrician who would then prescribe it. But I would certainly urge you, if you don't feel comfortable with making a prescription like that, to in fact send the. Oftentimes these are very well people. They don't have any other indications to be seeing an obstetrician, but refer to the obstetrician. If you are seeing somebody very remotely, that might be more difficult, although I'm sure that everybody's getting very good at doing Zoom visits or telehealth visits. There's a lot of other reasons why you might refer to an obstetrician, which are all included there and are in the risk factors if you look into the antenatal record. Postpartum, we talk about the many B's: baby, breast, bowels, bladder, belly, bottom, bleeding, baby blues, birth control, and blood work. And so maternity care is incredibly rewarding, and the maternity care pathway has it all. So just follow the roadmap. And please consider preterm birth as one of the risk factors, and call RTVS pathway if you find yourself in a rural or remote location and you need to call a friend, even if you're very well trained to manage the situations that arise, but just need a little bit of reminding about what to do. And I'm welcome. Any more comments?
Thanks, Jennifer. You ended right on time. Any closing questions from the group? There's one comment here saying that they need access.
Oh, it should have just worked. Sorry about that. Share. I think it should just work.
Is that the same for everybody? Can anybody open it up, or is everybody kind of stuck on the link?
Let's try again. I'll try and make a new one. Well, see, I just want to do it where you can see, anybody can see it, right? Anyone with the link. Here, we'll do this. I'll try again.
And while Jennifer's doing that, any other, yeah, you got another call. So thanks everybody for coming. And I hope you enjoyed that. Nice seeing everybody.